Welcome to the NAMI Finger Lakes Family Forum. I'm Beth McGee. I'm the Executive Director of NAMI Finger Lakes. Our family forum is held on the fourth Tuesday of every month. I learned the other day that it's been going on for about 11 years. So we're really happy to keep being able to bring you some great guests. This has been a joint program with Tompkins County Mental Health, and we're glad everyone could join us this evening. So I am going to introduce our moderator and also another volunteer who's helped coordinate this program. Anna Sambathy is with Cornell Health International, and Navya Chamiraju will be our moderator for this evening. This event is being recorded. And let's see, Navya is a member of Cornell Health International in the class of 2024. So we're glad that she can moderate for us this evening. And I'm going to turn things over to her now.
Hi, and welcome attendees and panelists. Thank you so much for being here today. And today it's going to be pretty much, we'll present the panelists with two overarching questions for the evening. And we'll also have an opportunity for an open Q&A later in the program. And we would appreciate it if you could hold all your questions until after all the panelists have had a chance to speak on these two questions. And before I get to the overarching questions for the night, I'd like to introduce our guests on the panel. And we're going to start off with the director, John Halaychik, who's the Communication Center Manager at the Tompkins County Department of Emergency Response. And he's also on the board of directors of Suicide Prevention and Crisis Services. And next we have Supervisor Susan Spicer, who's the Clinic Supervisor at the Tompkins County Mental Health Services. And then we have Deputy Vince Monticello, who is the Deputy Chief of Operations at the Ithaca Police Department. And finally, we have Deputy Matt Skeval, who's the Commander of Crisis Negotiations Team. And the goal for tonight is to answer two overarching questions. And the first one is how each of these panelists understands the mental health crisis response to be accomplished currently in the Tompkins County. And the next question is, what is their specific organization's role in that response? And first, I'd like to start off with Director John Halaychik. If you could just introduce yourself and what your role is in your organization, and again, answer the two questions. How do you understand the mental health crisis response to be accomplished in the Tompkins County, and what your organization's role is in that response? Thank you.
My name is John Halaychik. I am the Communication Center Manager for Tompkins County 911. I also serve as the board secretary for Suicide Prevention and Crisis Services. As far as my background is concerned, I've been involved in public safety for just over 30 years now. October 22nd was my 30th anniversary. I've worked in 911 communications since October of 1989. I've worked in the state of New York, I've worked in the state of Florida, and in the state of Georgia. I started as a line dispatcher and have worked my way up to my current position. I also am a New York State certified EMT, so I also have a field perspective in dealing with individuals that are having various needs with respect to mental health. When I worked in the Florida area, I was part of the Orange County Crisis Intervention Team. So we responded both as civilian and sworn personnel to mental health situations and emergencies in the greater Orlando area. I also serve as a volunteer at the state level for surrogate decision-making, end-of-life situations. And since I've been with Suicide Prevention and Crisis Services, I've been with the agency a little over 2 years now, working, volunteering at the agency and serving at the board, basically doing whatever I can to advance the cause for better crisis care with respect to mental health. So that's a little bit about my background, kind of many various different perspectives when it comes to mental health in the greater community. With respect to suicide prevention and crisis services, it all begins when they are contacted by a caller, and that caller could have diverse various needs. They may be in crisis, they may need someone to talk to, they may need assistance. It is really driven and dependent upon the information that they are beginning to present with. And then once they begin to speak to the crisis line counselor, that information is assessed, and then ultimately determinations are made whether or not the caller is safe, what intervention or interventions they may need, what type of assistance they may need. And then that begins to unfold and direct how the situation is handled. Each situation is unique. So what may be required or what is determined to be needed by one individual may not necessarily be the same for another individual. And then they can reach out or direct that individual to additional assistance or work collaboratively with other agencies to get them the assistance that they need. So that's one piece. Putting my other hat on from the 911 perspective, we tend to deal with more people that are in acute crisis. That is not to say that a person in acute crisis or in acute need couldn't contact SPCS, and they would need to begin to assist them at that level. But speaking from a 911 perspective, most of our callers are in immediate need of some sort of intervention or assistance. Now, generally speaking, that results in a joint response between law enforcement and EMS. There is a safety component that needs to be evaluated when you are accessing through the 911 system, and EMS will arrive on scene. A determination will be made as to whether the person needs to be transported to the hospital. Also, it depends on how the person is presenting. Are they violent? Are they disassociating? It all depends. It is very, very situational from call to call, and we have to adjust based on that information that is presented to us. So there's some overlap, there's some not between the intake portion of crisis services with respect to suicide prevention and crisis service in respect to 911. So that's an overview of how the access portion occurs between both entities. Now, again, once more, I'm sorry, the second question.
Yeah, the second question is what is your organization's specific role in that response?
So with respect to 911, taking them the opposite way, our role can vary. So our individuals are trained to a certain level to assess whether the person is violent, whether they have a plan, whether there are any weapons involved, and we can begin to have a conversation with them while we are routing emergency services to the location that they are at. But I would say 99% of the time, anytime that the 911 system is accessed, it is going to result in an emergency services response. Okay. With respect to suicide prevention and crisis services, again, there is an assessment piece, but each individual case there may not result in an emergency services response. And I would think that the majority of those situations would probably not result in an emergency services response. There is a lot of a support role and ensuring the general health and well-being of the individual. But we can also reach out to mobile crisis. We have access to other resources. And like I said, it's very situational. It depends on what the presentation is and what the best plan is for that person's general health and safety. So that's kind of an overview of your two questions.
Thank you so much for your input and helping us better understand how like the 911 aspect comes into this. Deputy Monticello, could you introduce yourself and give us a little brief description about what you do in your organization? And then again, talk about the overarching questions. How do you understand the mental health crisis response to be accomplished in the Tompkins County currently, and also what your organization's role is in this specific response?
Okay. My name is Vincent Monticello. I'm the Senior Deputy Chief of Police. I've been with the department going on my 39th year. So I've seen a lot of different things over the years. So our response is typically reactive. We may get a call from a certain location about somebody in crisis. Depending on the situation, we may have a situation where somebody will want to go to CMC voluntarily, and we'll do the transport, or in some cases, we may request the assistance from Bang's ambulance. And if that is the case, typically, we'll ride with them to the hospital and make certain that the paperwork is properly, turned over to the hospital with any information or questions they may ask. There's other times when, depending on the circumstances, that may be questionable. In some cases, we'll ask for the mobile crisis team to respond to assist us in doing some type of evaluation. So that's typically what we do. Going back a number of years, we were actually very proactive, where we did have a partnership with Tompkins County Mental Health, and it was a program called Resolve EDP, which was actually started by Lieutenant Bosal and Terry Garahan. And that was after one of our investigators was killed by an emotionally disturbed person. And that was very proactive. If we had field reports from officers, we would get that information through our records division. And back then, Lieutenant Saul and Terry Garahan would go through the reports and actually do some visits with these individuals. But now, based on that program was actually cut probably in the early 2000s when our staffing started to drop. And that's really something that if we had the staffing that, I'd like to see come back to our agency. But right now, with a lot of variety of reasons, cuts and so forth, that may not be practical. So unfortunately, we're a reactive role. We'll do we do the assessments to recap. If somebody needs to be transported, we may do it. We may call Bang's ambulance. A lot depends on the situation, how busy Bang's is, how the person is. If they're, very compliant, we'll do the transports and turn them over to the hospital.
Thank you so much. I would next like to invite Deputy Skeval to give us a little brief description about what you do and introduce yourself, and also how you understand the mental health crisis response in the Tompkins County, and also what your organization's role is in that response.
Thank you. Thank you for having me. My name is Matt Skeval. I'm a deputy with the Tompkins County Sheriff's Office. I've worked as the capacity of a police officer for over 12 years now. I also oversee our crisis negotiation team as the commander. We work in conjunction with our SWAT team on incidents that can be drawn out or last an extensive period of time, and that are, in some cases, a determination that increased personnel on scene would be necessary. We, and I'll try to speak in both capacities as the head of the SINT team and also as a road patrol officer. Really, we as road patrol are kind of the facilitators, or that have to meet in the middle, whether it's getting that first call from a 911 dispatcher and responding to the call of the person in crisis, but also determining, what do we have on our hands, whether it be somebody that's struggling with mental illness or a situation that's not. We try to, besides our focus is on de-escalating a situation, to not only keep the public and the people on scene safe, including the officers, but also in an effort to de-escalate the person in crisis. That's done through many hours of training experience. I particularly work with young officers at our department about rapport building, active listening skills, and how best to resolve a situation that can sometimes turn contentious, or in many cases, particularly when it comes to somebody struggling with mental health, can be unpredictable. In the event that we do end up taking somebody into custody, whether it be, I heard somebody mention before what would be a 941, which means it's a mental health law giving us the power to take somebody into custody to seek mental health treatment. The other thing we deal with is a 945 order, which would come usually from a doctor, usually by way of a Tompkins County mental health worker. That too would put us in the position to take someone into custody. What I've found throughout the years, particularly people that are struggling with mental illness that are in our community and have remained here throughout the years, is these are people that we're dealing with on a consistent basis. So it's always in the best interest of our officers to not only resolve the situation in a manner that is agreeable to the person in crisis, but making us all aware that this person will most likely be somebody we would be seeing again. Those attitudes and that behavior have certainly benefited our officers, and myself included in that. I think the second part of your question was, what is our role as the sheriff's office? So as the sheriff's office, our jurisdiction is included with the entire county. As we respond to these calls for crisis, we try to facilitate. One thing we've tried to make it a point to our newer officers is many times we'll go deal with somebody that may be in crisis or struggling with mental illness, but it may not reach the grounds of where we're going to take them into custody or bring them to the hospital. So what we've tried to do, particularly over the past couple of years, is make sure we're making contact with an agency like Tompkins County Mental Health to one, say, hey, is this person on your radar? Is he being seen by you? And if the cases that they haven't had an introduction, we'll make efforts to pass that information along to them in the hopes that Tompkins County Mental Health or other services within the county will reach out. As commander of CINT, many times we talk about being a negotiator. I think many people that are dazzled by the Hollywood lights would often think that we're there for bank robberies and hostage situations, and very little of the time nationally is that ever the case. In many of these incidences, we're dealing with people that are in crisis, that are sometimes barricading themselves, whether it be threatening harm to themselves, the occupants that are there within the home, or officers on scene. So in working with SWAT on some of those incidences that can be drawn out several hours, or we've had times where they've lasted days. Our goal is obviously always to peacefully resolve the situation, keeping in mind that we want to keep the safety of the public, the officers on scene, and the individual we're dealing with in mind. Thank you.
Thank you so much. And next, could Supervisor Spicer, could you introduce yourself and give us a little bit more information on what your role is in your organization and how you understand the mental health crisis response to be accomplished in the Tompkins County, and again, what your organization's specific role is in that response?
Well, I'm Susan Spicer. I'm the clinic supervisor, currently the interim director at the mental health clinic. I've worked for Tompkins County Mental Health for 20 years, for 14 years as a supervisor. And prior to that, I worked on the BSU at the hospital for 11 years in the social work department there. So I pulled up the questions, how do you understand mental health crisis response to be accomplished currently in Tompkins County? Well, from the perspective of the mental health clinic, in many different ways. Before I left the building tonight, there was a social worker in my doorway saying, I am really concerned about this client, and gave me the history of what's gone on with the client for the last the last month. And she wasn't able to really reach the client. And so that, as a result, she was going to end her day by doing a home visit and seeing if she could reach out to the person. We talked about safety issues. She was going to go. She felt she knew the client really well. She felt comfortable going to the apartment, and then figuring out from there. And then her next direction was to notify her supervisor at the end of the day what happened with that. So and that end of it, you know, we do crisis response all the time, not necessarily in the grand way of like a mobile crisis team or lights and sirens. We do crisis on a daily basis with our clients, right? And then a few years back, through a Care Compass grant, we started a mobile crisis team. Prior to that, we really only provided service during the daytime for outreach crisis. In the mobile crisis team, we work in conjunction with suicide prevention, and we are 24/7 service. And so that is the majority of what our organization's role in terms of the grander scheme, the mobile crisis team. We have a team of people who are social workers, nurses and care coordinators, case managers. They are on call, and as I said before, they get activated by suicide prevention. Anyone who is a client of ours can call the mental health clinic anytime, day or night, and they can access the crisis line, which will then put them in touch with mobile crisis if that's what's needed. We have, there are other agencies here tonight, so we work closely with the police department often, and also the Tompkins County Sheriff, and sometimes state police. A 945, I think, as was mentioned before, which is the mental health law that we use to involuntarily send someone to the hospital for evaluation, is really, from our perspective, is a rare occasion. We use it, but it's a rare occasion. More recently, there has been, I think, because of the COVID crisis and the level of distress, anxiety, stress that people are feeling, and certainly this is affecting the population of the severe people with severe mental illness more. There is more crisis response these days. There just is more crisis response. So let me see if I need to look at the second question is, so what's our organization's role in that response? Mobile crisis, certainly. Outreach, certainly. And I think someone mentioned before that often we get contacted by police agencies saying, we had a call last night with this person. Are they on your radar? So how do we get those people in and get them into treatment? So that's another role we have. Of course, we have intake and we have treatment. So I guess that's it.
Thank you so much for your input. And does anyone else have any additional thoughts once you've heard your colleagues speak on the topic and the role in the response? Well, then thank you so much for all of our panelists for giving us a better understanding of the overall mental health response, crisis response in the Tompkins County. And now I'm going to turn things over to Beth McGee to explain how the Q&A section of this program will be working. Thank you.
Thank you, Navia. I'm going to unmute all of our panelists, if you don't mind. And then what I'd really like to see is, in order for us to be as safe as possible, if people could use the raise your hand feature in the participants list to let us know that you'd like to ask a question, and then we can unmute you individually to do that. And if you have a question that you don't feel comfortable asking personally or out loud, you can open the chat feature. The button may be at the bottom of your screen, I think, and open the chat feature. And if you could send your question to the host, Anna Zompathy, if you can just send your question, and Anna will have Navia provide the question. Let's see, I don't think there's anyone calling in, so I don't have to give any explanations about phone. And so if everyone can try to use the raise your hand feature, then I'll be able to see you and unmute you or ask to unmute you to speak. So let's see, I'm going to unmute. Where did Susan go?
I think I'm unmuted.
You are? Where did you go? I can't see you on my screen. Oh, there's Marla. Yeah, and you can also use your little reactions. If you use a thumbs up like Marla did, that's great too. If you can't find that button for the raising your hand, the little hands clapping or the thumbs up are great too. So, Marla, welcome.
Hello. Great topic to bring up. I was just wondering, Deputy Monticello had brought up how resolve used to be in the community. So there was more proactive checking in on people with known mental health diagnoses. Do you think with the governor's push to have these discussions about how to respond to mental health crises, how we can reformulate our response in our communities, that there is the possibility that we could backtrack to something that worked in the past there in Tompkins County?
Deputy Monticello, did you hear the question?
Yes. Was that directed at me? I was the one that
Yes.
brought it earlier.
Yeah.
You know, I can speak for our agency. It's a lot's going to depend on staffing right now. I know in the past it was just one of those extra duties that in the case Bo Saul took on as part of his regular patrol duties. So I mean, that's something we can certainly look at, and I can certainly recommend that to the chief of police. He'll have the final say on that. But you know, it was a very effective program. You know, the person that in this case, you know, Bo Saul and Terry Garahan worked very well as a team, and they were, you know, nationally recognized. As I recall, there's a New York Times article and I think 60 Minutes to the story on their program. And it was very effective. It was proactive. You know, unfortunately now with our staffing, we're more reactive, which really isn't the best way for us to operate, but we have to work with what we have. So I can certainly, you know, recommend that moving forward.
Thank you.
Can I just add to that a little bit?
Please.
We still have some communication a few times a week with IPD. What happens is that there are, I think there are assigned officers that communicate with Christy Bianconi about people who are out there and perhaps in need. And that information gets shared with the mobile crisis staff. And we have a person who 50% of her time is dedicated just to doing outreach and she also does mobile crisis. And so she is able to do some outreach to people. She can call them, she can mail letters and say, please call us and we'll get you some services. So that's Joanna Sturgeon. So we do have some semblance of that still exists.
That's correct.
Any other questions? And again, if you just scroll over the bottom of your screen, you'll either see reactions or the chat. And if you, in the chat, you can choose that you want to raise your hand if you'd like, or you can just choose a reaction, which would just be a heart or a smiley face or a thumbs up or whatever. And then we'll see it on the screen. It'll bring you up to the top, I guess. I have a question. Susan, just a couple questions for you. Does a person have to be already engaged with Tompkins County Mental Health Services in order for TCMH to request that a person be involuntarily hospitalized?
No, not necessarily. However, the idea behind a 945 is that a reporter is someone who most likely has a relationship with a person. That's the most ideal way of doing it. A therapist who's concerned about suicidality, something along that line. However, there are other people who are what we call valid reporters. And those people, and I will not be able to list them all off the top of my head, but a parent, a sibling, an adult child of a psychologist, a nurse, a social worker, in some way, in a very limited way, case managers, but those case managers have to be associated with an OMH program. So case managers, for instance, from our building, but not case managers from Southern Tier Care Coordination. So that's a little, that's an OMH regulation. So there are people who can be a valid reporter. Now, that has to be investigated by the designee, that there is validity to the report. So I would say the majority of the 945s we do are people that we know and we have a history with. It is not always the case, though.
Thank you. And on another topic, I'm wondering if after our experience during COVID, when things were shut down and the mobile crisis unit wasn't responding due to like PPE and just safety issues, I'm wondering if we're working as a county on a plan on how to move forward in the event that we have to do another shutdown, as the numbers spiking, for mobile crisis to continue in a more regular way.
Yeah, I mean, and for every service, right? I mean,
Yeah.
we're starting to see people back in the building, groups that need our services. Young children, for instance, can't do Zoom, right? It's not possible. So there are groups of people that we are seeing, and we talk about this, that there's a likelihood that there'll be a surge at some point and we'll have a lot of people back at home. However, now that protocols are in place, we feel safer about going out. And I don't believe that we'll go back to telephone services only for mobile crisis. We'll still be out there.
Great, thank you. I saw Amanda Kelly. I had a check mark by her name. I'm asking her to unmute. Amanda, do you have a question?
No, I just wanted to give a thumbs up for a good speaker.
Oh, great. Thank you. Thank you. And Deb Grantham. She is our president of NAMI Finger Lakes. Just put a thumbs up. Did you have a question, Deb?
No, I didn't. I was just pleased to hear the response from Director Spicer about we probably won't go back to only remote responses. I'm happy to hear that. They have to be done, but they're limiting.
Mm-hmm. Right. And also, I'm going to unmute Tammy Baker, our community outreach worker. It did occur to me earlier, and she just mentioned it, that our community outreach workers really are dealing with crisis often on the ground, and de-escalating crisis too. So they play an important role in that. Tammy, do you have any comments? Would you like to speak on that?
Yeah, thank you. So, I mean, during the whole COVID crisis, Natalia Kowalik, because she's the other outreach worker, we continued to go out and we work really closely with IPD, not necessarily the sheriff because we're mostly downtown, but with IPD and Tompkins County Mental Health. So we deal with a lot of mental health concerns that are happening in the community. We work really closely. Like if I have a concern about somebody, I touch base with Susan and say, hey, I'm working with so-and-so. She'll help me decide whether it is a 945 or not. They know people really well, whether they would actually be accepted at the hospital, given the status of the person at that individual time. But so before they actually get the point of crisis, we deal with a lot of individuals in the streets that present with mental health. So we're available Monday through Friday, 9 to 5. And often when IPD, if the police department gets called, they know us really well. And if it's in the time frame that we work, they'll call us and say, hey, Tammy, this is something this is more of a social work thing rather than something for IPD. So we have that relationship. It's not exactly what the resolve was that Mr. Monticello was talking about, but we actually have, we're building that program right now. We just need more people actually in the streets, meeting people where they're at out there. That's a really helpful component. And actually recently when I was in the jungle, a sheriff deputy was out there bringing a family court order to somebody. I just happened to be out there with Reach Medical at the time, and having a social worker out there with, whether it's a sheriff or an IPD officer, really softens the introduction. The woman was in her tent. She didn't want to come out. She was swearing all sorts of things, but I was able to create that bridge. So having a social worker available, whether it's with the sheriff or IPD, is really essential. Even when it's not a full mental health crisis, we need that for lots of situations in our community.
Thank you. And I just want to remind everyone that it is set so people cannot unmute themselves, just to make sure that no one bursts in like before, and we're not able to control that. So if you do want to ask a question, you won't be able to unmute yourself. You will have to do the raise your hand. I have a question for all of the panelists, actually, based on the events last night, I believe in Philadelphia. The person that was experiencing a mental health crisis, he was shot in front of his mother and on the street, and it looked like a very chaotic situation without much planning. And I'm wondering if any of you would like to talk about what's different here. What's different here about our response that you think is different here? That would prevent me as a mother from having to experience something like that and my loved one from meeting that fate. I know that's a tough question.
Yeah, I'll answer that. It is a tough question, and things could happen very quickly. It doesn't take too long before somebody is, stabbed by an assailant, and I'll use Investigator Padula as an example. And as a result of that happened very quickly in a closed area. And as a result of that, a lot of changes did happen afterwards. And I think what we have today goes back to, what happened back in November of '96. So what happened in Philadelphia, I briefly saw it on the news. I'm not going to second guess what they did right or didn't do right. Obviously, not all the facts are there. Obviously, no law enforcement wants to take anybody's life. And, again, it's maybe we're fortunate that, we are a small community. Maybe we have that dialogue with our residents, and we have the partnerships with the different mental health workers. And Tammy Baker, I neglected in the beginning to mention her, but she's been very helpful, as well as the other case workers that do help us. So maybe that proactive approach on the county side of things and the private partnership does help us to mitigate some of these situations, whereas perhaps in your larger cities, they may not have the resources there on the mental health side to deal with things like this. And they are tragic.
Thank you.
I actually had the same thought. I was thinking, Vince, I was thinking the same exact thing. I thought about Officer Padula, and that started a collaboration between law enforcement and mental health that I think is still sustained to today. I think the fact that I agree too that we're smaller. We are a tiny town, that we run into each other in the grocery store, and the other thing about this is that when there is a distressing response, when someone is not, when you have a person who's just suffering from significant symptoms, and it's a very stressful ambulance ride to the hospital, getting them in the ambulance, there's a trauma to that, to the people who are doing it as well. And so there's a bonding around that stuff. So we don't want we don't want to see anybody get hurt. I don't want to see anyone from IPD get hurt. I don't want to see anybody from Bangs to get hurt. So there's an investment that we have in each other. I think that we are good collaborators.
And
Thank you.
Beth, I would add into this, and this is speaking from the 911 perspective. I don't know how that call routed into their public safety system, but operating from the presumption that a 911 call was placed, what's inherently critical for us is that whoever the caller is that is reporting the situation, what is their state of mind at the time of the call? And just from what I don't know much about the Philadelphia incident, so I can't comment on the end response, but it varies from person to person as to their state of mind at the time of the call. So if they're an immediate relation to the individual, they could be very calm having a conversation like we are now, or they could be very escalated, and the dispatcher will have all to do just to get them to de-escalate enough to determine the location and some basic information. We always hope that we can get as much information as possible. Specifically, are there any violent tendencies? Are there any weapons involved? Because that changes the complexion of the situation. The other piece is if an individual is presenting in a violent manner, or the caller should indicate to us that they have a history of violence, or indicates to us specific triggers, we're going to relate that information to our responders. EMS is going to be staged away from the scene until the scene is deemed secure and safe for them to enter, if they need to render any psychological aid or whatever it is that they are needed for. The other piece is we're going to stay on the line with the caller, especially if there is an active in progress need for us to stay on the line with the caller until some sort of assistance arrives. The way a situation starts out and the way a situation finishes at the time that someone arrives on scene could be very different. And the other piece here is that not necessarily all the time, just in the way the situation unfolds, is all that information communicated. That's not to say that the person is withholding information. It's just that circumstances get away from a caller very quickly, and they can't articulate that to the 911 dispatcher, who in turn is going to relate that to responding units. So there's a lot of things that occur in a very short period of time. And really it's all predicated on how the caller is presenting and what they can communicate to us. So that's the pre-arrival piece that doesn't even begin to touch when services arrive on scene. But that's what we're looking at on a daily basis.
Hey, Beth, I would just like to add that I'm unfamiliar with the circumstances you're talking about, but certainly in law enforcement in my 12-year career, and in a recent conversation I had with the deputy chief, we reflected on, in his many years of experience, does he think this day and age as a police officer is more difficult in from the men and women in our law enforcement who've been doing this job for, sometimes more than 20 years? Most of the answers have always been yes. So the really, to broaden kind of your question is, how do we as law enforcement and the community work with a community that sometimes appears to not trust us? And I've been on those calls many times before. Is, well, I don't like cops, and I always use it as an opportunity, and so does our officers, to maybe either dissect what the situation they were involved in was, or get an understanding, because many times there's a misunderstanding as to the action law enforcement took, or sometimes many people are have a negative view of law enforcement, particularly just because of what they're perceiving on social media or in the media. So we make every opportunity to do that. And just additionally, kind of what John said, I don't know if anybody knows this, but we, every law enforcement agency in this county is on the same communication system. For example, so when somebody calls 911, we have a system called Spillman. There's a national company, and they work with many other agencies across the U.S. And this Spillman system comes up as a CAD in our police cruisers. And not only do we see the information that the dispatcher took on the 911 call, but one of the most important things, and really that's benefited me in my career, and the use of technology, is anytime we're interacting with someone, even if you were just involved in a simple car, deer, motor vehicle accident, your information or your name would be logged into our system, and we can see that history. So for me, if I'm ever, or the officers around me are going to these critical incidences, or someone in crisis, in so many of these cases, the vast majority, this is somebody that has had prior dealings with law enforcement. And then for the officers to take the time before they get to that call to not only brief themselves on the situation that they're walking into, but what's the history there. So that ability for us to use technology, and like I said, that program is used. Every agency, with the exception of Cornell University and Ithaca College, are on that same communication platform that really helps us log a good history and know what we might be getting into before we get there.
Thank you. Thank you. I appreciate your answer. Navia, did you?
Oh yeah, thank you so much.
Yep.
There's a question, but it hasn't been sent to me yet. Here. So this is for the law enforcement agencies. Are there 911 response calls where you feel that other professionals could better respond to the crisis than the police can?
Yeah, I can answer that. Yeah, certainly. Each call is unique, but a lot of times we are put in positions where somebody does not know who to call, and so that we end up being the ones that are called for certain situations. So, yeah, I think you have to look at the big picture, look at everything, look at each individual type call, and perhaps the history of the individual in question. So yes, there are sometimes, especially with our limited resources now, that we have to be more creative, and there's going to be less reliance on law enforcement and perhaps more on the mental health side. But those are decisions that are going to have to be made on the mental health side, and how comfortable they feel responding to a call that could potentially turn violent. And it's not a perfect system. We saw what happened in our station back in December of last year, and that it was a very small area, and the person that assaulted our officer, it was just out of the spur of the moment, where he became violent, and it was an ambush type of an attack. So, but to answer your question, it's definitely something that's going to need to be discussed further with mental health and in our agencies, and as well as some of the other law enforcement agencies. What calls do you want us handling, and what ones you feel comfortable going without law enforcement?
Matt, do you have comment with that?
Yeah, I mean, I would agree with the deputy chief. I think I'm hearing this national conversation of well, why are we sending police with guns to somebody that's in crisis? And the reality is so much of these situations, and our 911 dispatchers do a tremendous job at trying to get information from callers, but I couldn't give you a number, but many of the calls that come into the 911 center, whether the person's in distress or the other participant or complainant is in distress, it's very difficult to get specific information. And in many of the cases and throughout my career, these incidents we're going into are not only unpredictable, but could show themselves or to a dispatcher in a certain way. And then you get there and they certainly were not what we expected. But I think our county is doing a tremendous job in, realizing, and I work with my young officers to explain to them, hey, they would, sometimes you'll hear them say, well, this doesn't seem like a police matter. This person's, suffering from mental illness and they're in a manic state, but they're not going to kill themselves and they're not going to kill me. And, they don't know what to do. Like I said, those are great introductions to get these people on the radar of some of the community services that are available in this county. And these things help, quite frankly, lighten the load of the police to deal with other matters. Not to say we don't want to deal with those things. And me in particular, I enjoy those crisis situations and trying to be there for somebody, but reaching out to another agency that can step in and maybe prevent from future incidents from occurring is kind of where I see this going with law enforcement in the future.
Thank you. Micaela, Corazon, you have a question?
No, I just wanted to comment. I
Okay.
run the crisis line at Suicide Prevention and Crisis Services.
Great, thank you.
And thank you, John, for offering leadership. And we work with a lot of y'all. When someone calls the crisis line, we do an assessment for imminent lethality, and we also create safety plans for individuals who have expressed suicidal thinking, suicidal ideation, and we offer callbacks and touch base with them when if they agree to secure a safety plan. We've been working a lot with Mobile Crisis Team. They've been calling us at the end of a very harrowing week and telling us who has 945s out on them. This past weekend, we were keeping that information for 9 individuals, knew that the Mobile Crisis Team and the police had gone out to these individuals' homes, and the individuals would not let them in the house. So, and the assessment was, well, there is no imminent risk here that we can detect. So, we'll see what's happening. Lakeview calls us a lot for their residents at the SRO or in individual or congregate homes around, and to warn us about potential mental health issues that may be coming up so that we are on alert. Every time I call somebody on the Mobile Crisis Team, I apologize profusely because I know how busy they are and they are exhausted with the amount of Mobile Crisis Team calls that have just happened since the COVID shutdown is really extraordinary. That people in imminent distress. We also work with the campuses. We work with Cornell Emergency Management. We get calls transferred to us from other crisis lines where there's a Cornell student calling and they get routed to that crisis line because of their cell area code. So, we're able to inform them of the mental health support that's on the campus right now with 24/7 therapeutic support, the Let's Talk program, and we've also worked with the Cornell police around emergency situations. We haven't had so much interaction with Ithaca College, but of course Ithaca College now is online. I don't know if anybody's, very few people are working on the campus right now. So in terms of doing this community work, people who do call the crisis line, we have family members who call the crisis line and we refer them a lot to NAMI. We talk about how NAMI can support them, can also offer them education. We really, talk about the 12 session program that you offer families so they can teach themselves about navigating the mental health community. because those calls will break your heart, mostly from adult parents who have adult children with severe mental health issues, and they're trying to figure out how to help their children. So I just wanted to let folks know that, we're there, and thank you for the leadership. We have several of our leaders actually on this Zoom who are there, volunteers who are there in leadership to help us continue to do this work. And yes, we do answer the line at 3 o'clock in the morning if somebody from the mental health clinic calls. And at that point, we assess for immediate danger to harm to self or others. And we call the mobile crisis team if that is appropriate, or we call 911 if that's appropriate. And we do education. We let people know what will happen when 911 comes, or what will happen when the mobile crisis team comes. And we do say that they will come with law enforcement for everyone's safety. People don't, we've gotten feedback from people saying, why are the cops coming with the social workers? It's for everyone's safety. So we do that education too. So I just wanted to make that comment.
Thank you very much for that perspective, Micaela.
Thanks
for joining us.
Thank you.
Navia.
Yeah, thank you so much. Another question came in, and this isn't for anyone specific, but just general question of what is the Cayuga Medical Center's role when someone is sent to the emergency department on a 945?
Would anyone like to speak with that, Susan?
I guess I'll answer that. So when someone is sent on a 945, they're required to do a mental health evaluation, and what they're required to, and then figure out a disposition for that person. Mm-hmm. If the feeling is that the situation doesn't warrant an admission to the psychiatric unit, the BSU, then they will do follow-up, maybe connect them with us, or reconnect them with us. So they just expanded. They've had a 3-year renovation going on, but I believe their adult unit has 20 adults, and then they have a swing space which can take either a child or an adult, and then they have 6 adolescent beds. So.
Thank you. I have another question, actually. I'm sorry. John, did you have a comment you wanted to make?
I just wanted to go back to the previous question and just elaborate just a little bit as far as the situation with respect to 911. One thing I would ask everyone to understand as well is, and I did a cursory poll on statistics today for our responses at the county level on the medical side of things for mental health emergencies. And there have been 304 cases since the beginning of the year. Now that number strikes me as actually being low, which ties into my point in that mental health emergencies or mental health situations often are concurrent with other types of calls that we would receive into the 911 center. And it's very important to understand that a domestic situation or some sort of disturbance could have underlying mental health aspects to it, but may not be the complete situation. So when you're looking at data from the 911 perspective, you probably have to drill deeper and beyond the 911 center itself, because you would really need the field provider, whether it be law enforcement, EMS, whomever, to give the other side of the scenario as to whether there is a mental health component. And I think if you begin to look at it that way, your mental health numbers for people in need that are accessing through 911 is actually a larger number than what our statistics on the intake side would actually look like. So I want people to understand that it's not always just very cut and dry a mental health issue, that there are other related issues that often go hand in hand with people that are in crisis or in need of mental health assistance.
Thank you for acknowledging that. We were actually, we suspected that when we were reviewing the information that both Chief Nair and Sheriff Osborne had provided in their presentations last week, that many calls such as like a wellness check on someone or a domestic call, something like that, or even just a disturbance somewhere could potentially be a person that is behaving erratically or something, and they don't necessarily pinpoint that right away as a mental health call. So it's good to know that. I'm wondering, how can we drill down further on that? How would you recommend we get that information so we can better understand the numbers that we're looking at here?
And I'll just speak from my end. It wouldn't necessarily be easy. What I would envision is your starting point would be the data that could be obtained through the 911 center. That would give you somewhat of a baseline. Where follow-up comes in is with the respective law enforcement agencies. And again, I don't want to speak as to the legalities of what information can be shared and not shared, because it's very nuanced. So that's not to say that people wouldn't provide the information, it just has to be provided correctly. Potentially, you would have to look at the end resolution of the situation, and also you would be to your medical center what the end resolution would be. And there's definitely HIPAA considerations all the way across as far as obtaining information. I'm going to defer to the law enforcement members on the panel because they can better speak for their agencies. And I think that's probably the best way for them to answer on their end.
Thank you. Vince, do you have a comment on that question?
We had some conversations, and this was before COVID, before the budget impacts, about establishing an analyst to look at all our data, all our calls that come in. And I mean, there's other agencies that do that. And unfortunately, I don't see that happening right now for the budget year for next year. And maybe it's something that can be revisited again. Because we have a lot of calls that come in, there's a lot of information. And a lot of that, to track it all, it really needs to be analyzed so we can see what the trends are and utilize our resources more efficiently.
Thank you. Deputy Skeval?
Yeah, it's just to piggyback off what John said, it's never usually cut and dry. You may be going to a situation that appears that it's a domestic dispute. For example, I just went to a call the other night where the mother was telling me that, her 17-year-old son was crazy and he was out of control, and using kind of the technology I was explaining before, I was able to review before I got there that the mother actually was the one with a long history of mental illness. And so with those situations, and I got there and it was very clear to me that this young man was in a very difficult situation, that he just moved back with mom and she was certainly struggling, but she certainly wasn't at a capacity where she was a danger necessarily to herself, but I got her son to a safer environment. But many times I think when administrators or even dispatch is looking up the statistics for these numbers, it's never cut and dry. We try our best when we close out a call. By close out a call, I mean how we do it electronically with an actual, not only a report, but a disposition as to what the nature of the call was. And like I said, whether it's a welfare check, whether it's a psychiatric complaint, whether it's an assist to Tompkins County Mental Health, it's so broad, our interactions with people in crisis or having mental health that I'm sure it'd be very difficult. And I would guarantee that 300 is nowhere close to what we're dealing with. I mean, then if you're saying 300 number, I probably make up 25% of that number. So there's no way that number could be accurate. But I'm sure they're just quickly trying to gather stats with these certain natures of the calls.
Sure, thank you. Navia has a question from the chat.
Yeah, this question is just to the general panel. And their question is, in some places in the US, mental health crisis calls don't involve violence or crime, and they're responded to by an EMT and a mental health professional rather than the police. Could that work in the local Ithaca area?
So like I said, I think we've kind of touched on this, but working with these additional agencies to try to circumvent future responses or helping out community members with, Tompkins County Mental Health or the ACT team, which is a state-run mental health agency. But I would ask people just to consider, if your son or daughter, chose a career path of being a paramedic for Bangs Ambulance, would you want them to respond to a call where their job and their profession and their training is to help someone in need of medical attention? Would you want them to respond to a call with their unclear whether their safety would be at risk? I think that would be a detriment to our community. And I think it would just be really hard to put mental health service workers and people, whether they're paramedics or medical staff, in the position to go to an incident. And many of these circumstances where the dispatcher kind of gives us an indication that we think we have somebody here that's either suicidal or in crisis. In many of these aspects, they are dispatching emergency service workers or the ambulance to go with us.
Anyone else?
Yeah, I would agree. Particularly, we've seen, in other places where firefighters or EMTs have been, ambushed responding to calls. So I don't see it being a practical option here locally.
Thank
So
you.
I know that we've discussed different models. I think when the mobile crisis team was first forming, there are various models around the country. It is an interesting time because you probably know the Office of Mental Health is talking about a 20% reduction of funding next year, right? So any agency for OASIS, so those are substance use disorder agencies, and for mental health. So do I think we should stop talking about it? No, because the one thing that we know about the current COVID crisis is that we are doing things differently. It sparks our creativity in some ways because we don't have choices about the way that we can, we don't have all the resources available to us. So I think it means we just keep the conversation up. I think that we keep talking about and thinking about different ways of doing things.
Thank you. I have I think just my last question. I'm wondering, since NAMI represents families, what could families do to help with mental health crisis response from your perspective, in whatever roles you're playing? How can families help with that?
Hey, Beth, for me on the patrol side, you and I have had many of interactions and I'm aware of the services, but I know most officers are not. Increasingly, we're responding to calls of parents. Basically, as you know, it's somebody that has either a son or daughter that's struggling with mental illness. Parents are at a loss at what to do, and they're petrified and they're scared and they want to do whatever they can, but they're also going mad themselves trying to deal with the illness of their their relative or somebody lives in the house. So I think we as officers need to do a better job at trying to get some of these parents who are looking for some assistance to turn your way, whether that be business cards or, in the past, I know we've had organizations come into a briefing to just let, officers, working the road, hey, here's just another entity or another non-for-profit group who's here to try to assist you guys or the families. So whether we get either pamphlets or cards, but we just need a better job at letting officers know that there's a group like you out there that can assist these families that are struggling.
Thank you. And I will say I did speak with the crisis negotiation team, and Deputy Skeval was there. I really, really appreciated the group's interest. They were very genuine in their concern and interest about a family perspective and really trying to gain that. We spent a good couple of hours at least talking about it, and I really appreciated the time and their interest in that. I'm wondering, John, if you have thoughts about as with regard to suicide prevention response and also the 911 dispatch response. You did mention a few things that people could do, or, you explained a few, like how people who call are trying to navigate the situation. Do you have any further thoughts on what people can do to prepare for something like that?
I think one of the critical elements on both sides, both from suicide prevention and crisis services, as well as from 911, and I will say SPCS does a tremendous job as far as the educational component is concerned, but it is that public education piece. First part is what resources are available. Second part is, and are you speaking broadly or are you speaking still in terms of the family dynamic?
I'm just like, for your perspective, I'm wondering about in the time of the emergency, what can people do? These are things that we may likely have to have happen in our life, and just maybe having some sort of a plan in the back of our mind about how to move through that process if we were to call 911 in a crisis.
So if you're calling 911 in a crisis, I'll explain this in two ways. If the individual is first party, meaning they themselves are in crisis or in need of services, and then second party or beyond, so it could be somebody in the residence or in the location with the individual, or removed from that location, but a family member that lives in another part of the country or another city. There's an economy of time. So presenting what exactly is going on at the point in time that the 911 system is activated, that's going to be the first thing. And beyond that, the location of the incident. Is there any relevant past history that we need to know about right up front? Specifically, are there triggers? Because we're going to want to convey that to whoever we're sending to this location. And the last thing we want to do is have any of our field responders walk in unprepared, and all of a sudden a trigger is presented and now a situation is escalated unnecessarily. As best you can, remain as calm and gathered when you're talking to the 911 dispatcher. That is dependent on the situation. That's far easier said than done. Sadly, there are times where a situation has escalated to the point where a person has ended their life in front of the caller. And the first call that we get is that they visually watched a loved one end their life. And to begin to try to ask that individual not to have an emotional response and present cogent information to the 911 dispatcher. Some people amazingly can do that, but a lot of that is predicated on how they react to that type of stress. And other times you may be fortunate enough to get the address where you need to go and nothing else. So I could sit here and make recommendations, but in the moment, especially in an escalated situation, really we're going to try and do the best we can. And I think from our end, our personnel, we want to remain as compassionate and empathetic as possible should it be a situation like that, or even with a first party caller. The holidays are approaching, and generally speaking, we take far and away more calls in the holiday season, people contemplating suicide, whether they have or have not developed a plan. Many times it's because they're depressed or they're lonely, or at least they're presenting as such. And they call 911, not necessarily looking for a response, but just because they want to talk to somebody. So again, as I said in the beginning, a lot of this is very situational depending on the presentation, and our personnel adapt based on those situations. But if you're accessing 911, give us as much information about what's going on as possible. Any safety concerns, remain as calm and collected as possible. And if we ask you to stay on the line with us, please do. That's another thing. It's a general thing when it comes to 911. The passage of time from the time that a 911 call is placed to the time that someone arrives to render help or assistance to the caller, that can seem like eternity. And it may in turn only be 5-6 minutes for a person to get there from the time that 911 was called. So lots of different things going on, but I hope that answers your question.
Thank you. Okay, so we are heading toward 8 o'clock. And as I said before, I do want to remain respectful of our guest time. We've covered a whole lot of information here. It feels like we know a lot more than when we started, for sure. If anyone would like to make a final comment, if anyone would, hold on one second, I'm sorry. Yeah, if anyone would like to make a final comment, if you could please use the raise your hand feature or send me a message or the hosts a message, that would be great. I'm just gonna check the chat really quickly. Deb Grantham.
I do want to thank everyone for this really good conversation. It's helped me think through this a lot. I'm wondering, Beth asked, what can NAMI do? It's really hard to go and do something like this if you're not in crisis. It's too late to do it if you are in crisis, but I'm wondering if there are chances for families to roll, if we could make chances for families to interact with all of your services in a way that helps both sides. So role plays or something like that we plan ahead. A lot of the people who maybe could benefit a lot from it may not join in, a lot of the families, because it's very hard to do something like that. But just wondering about possibilities like that. Would you all be open to something if we could come up with some ideas that might work?
Sure.
Yeah, our agency in the past has, opened up opportunities for, particularly last year, we dealt with parents that, I forget what organization they were with, but their children struggled with mental disorders, particularly certain intellectual disabilities, and they were very concerned about, how would law enforcement interact with their child. So having those opportunities, if anybody's interested in reaching out to my agency, just please contact the host and send me an email. We've had those opportunities before. And then I would tell people not to pass up any opportunity. If you see a police officer in public, please engage with them. It's the part of the job we like the most when we're just approached by somebody that just wants to hear more about our job or has a question or wants their loved one to get to know an officer from a different perspective. So just from a day-to-day perspective, please do that. But if anybody's interested in meeting up at my office regarding some of these questions and what you can do to work with us, please just email me.
Thank you.
And Deb, oh, go ahead, Susan.
I was going to say that anything, I don't remember how many times I've done family forum. I think I actually did the very first family forum. I think it was me. I think Rich was interviewing me. I don't know. But I do want to say that you're so important. I don't know that you understand. I have to tell you that in the last 5 months, I've made more referrals to NAMI than I have in the last 5 years.
Well,
I mean, it's really, so we have parents calling us all the time, like, I don't know what to do. They're just beside themselves. So Deb Grantham, I will think about like what we could do. I'm happy to help, but I want to thank you, for what you do. It's so important.
There are a lot of us working on it. It's hard, but it's important.
I agree.
And the question I asked is very hard. I don't know how to do that.
Sure.
I don't know if I could do a role play about my family member, but I'm just throwing the idea out there to stimulate thinking.
Sure.
Just to add into that, 2 things. One thing that Deb, you asked, and the other that Susan just touched on. As far as the 911 center is concerned, one of the things a number of years back now, I think about 4, we mandate that all of our dispatch personnel go through a program, first responder disability awareness training. And what that takes into consideration is a range of disabilities, whether they be intellectual, whether they be developmental, whether they be psychological. It runs the gamut. And for many individuals, that training is the very first time that they see or have an interaction with any member of any of those communities. And the takeaway from the training at the end of the day is I have an entirely different perspective of how to interact with someone who may have any of those disabilities. And that's inclusive of anyone that may have a mental health issue or be in crisis or what have you. And part of that is, to a certain degree, and it could be developed further, role play scenarios. The other thing that Susan touched on is that everybody here, it's an interactive chain. Okay, and we all are in this situation together. We all serve functions within the community, but at the end of the day, we are interdependent on each other with respect to this specific issue. And whatever we can do to help out each other, I think should be one of the common goals that we go to. So I just say thank you to everybody that's here this evening.
Thank you. I did have one final question that was in the chat. One second. Does anyone here teach about psychiatric advance directives? Or do we know of anyone who does? Perhaps we could share that. If anyone has any information about that. I know we actually we get a lot of questions about that in support group. Family members asking questions about this. I know Mental Health Association, they do the RAP program class, and I've been wanting to do that class for a really long time. And just the idea that a family member of ours would have an opportunity during a time when they're doing okay to make some really good decisions for themselves and be empowered to do that. That's really helpful to families as well as them, to help them make decisions and choices when things aren't going so well. I'm wondering, Josephine, do you have any comments about that?
Hi, yes, Beth. Hi, everyone. Thank you. This is a wonderful conversation. Mental Health Association does do wrap groups one-on-one or in groups with people. We do have a section on advanced directives, so we can help people work on that. And I also want to mention mental health first aid training. There is even a law enforcement module that we can provide. We have had some law enforcement in the training, as well as EMT individuals. Mental health first aid, we're trying to make it as common as CPR training. So if you are all interested, please get in touch with us at Mental Health Association. We have 3 certified trainers on staff.
Thanks, Josephine. I appreciate it. Okay, so we're a little after 8 o'clock. And I want to turn things over for a minute to our moderator, Navia.
Thank you so much for everyone's input today. Just as a final ask, do any of the panelists have any final thoughts that they'd like to share right before we conclude?
I just want to say thank you for doing this.
Thank you.
Thank you. Same here. Thank you very much.
Thank you.
Thank you.
And thank you. And now that we're done with final thoughts, I'd like to thank everyone here, the attendees and the panelists, for taking time from your day to be here to learn more about how the response to mental health crises are like in Ithaca, and to learn more about it and get an insight from 4 different people who are very specialized in their fields. So thank you so much for joining us today, and I hope you'll learn something, and yeah, have a wonderful night. Thank you so much.
Thank you to Navia and to Anna, our Cornell Health International volunteers. We're really grateful for their help in coordinating this. And I'll also say this will be recorded, so you can share with people without the interruption that we had earlier. So thank you everyone for coming. It's been really a great evening. Appreciate it.